My name is Zenos Mason. I'm a movement disorders neurologist at the University of Southern California. So I'm down in Los Angeles, but I do work closely with the Neurological Surgery department at USC because my role is as the director of the Deep Brain Stimulation program for our academic hospital, and as the lead for the new Deep Brain Stimulation program for the LA County Department of Health Services. So this is something I'm very invested in and I'm interested in, because in appropriate circumstances, it can really improve function and it can change lives for the better. So it's something I'm passionate about educating people in. And I find that there's always a lot of questions, so please do interrupt me. And I also find that people have often had these talks and a lot of education from device companies. And I just want to be clear that this is my disclosure slide. I have been a paid consultant for Boston Scientific, which is one of the device companies that make DBS devices, and I'm currently a paid consultant for Abbott Labs. But this talk is completely outside of any industry influence. So there are three devices, and I'll tell you more about them. Manufacturers are Medtronic, Abbott, and Boston Scientific. And you'll hear different talks from all three device manufacturers. I just want you to be aware that, as you know, device companies, just like pharmaceutical companies, are invested in you getting their device. And so all the information you get from those device companies is somewhat biased towards their device. That's fine. You take that with a grain of salt. Nothing today is biased in one particular direction. So what I'm interested in telling you about is the following. First of all, a history of DBS. So where does it come from? How does deep brain stimulation actually work? How does it work to improve symptoms, at least insofar as we understand it right now? And then the factors to consider. This is the who, what, where, when, and how of deep brain stimulation. So we'll go through each of those in turn. And then I'm going to talk about new and future innovations in deep brain stimulation. And this will cover all three of the device manufacturers, Medtronic, Abbott, Boston Scientific, because they all do have their advantages and disadvantages. So that's our roadmap for the day. And we'll talk in the question period about maybe how to choose a good surgeon, because that's nuanced to where you are geographically and what kind of priorities you might have. But I think everybody in this field is pretty well educated and pretty well immersed in the neurosurgical sort of environment of the state of California. So if you have any questions about that, then I'm happy to field that. First of all, history of deep brain stimulation. So where have we come from? This is a therapy that feels new, but is in fact now 2 decades old in terms of its FDA approval, and about 100 years old, or maybe 80, in terms of the scientific basis for deep brain stimulation. So going back all the way to the 1940s and 50s, we're looking at the earliest experiments, even in the 30s, in Wilder Penfield's experiments at the Montreal Neurological Institute, to use electricity to understand how the cortex of the brain, that's the outside of the brain, functions. And he, during neurosurgical procedures, would directly stimulate those areas of the brain and evoke movement, or sometimes certain smells or sounds, and thereby mapped out different functions of the cortex. Those were the first experiments to use electrical stimulation in the brain. Essentially, the field moved ahead dramatically when, in the 1940s, Spiegel and Weitjes introduced the neurosurgical stereotactic frame. So this allowed brain surgeries to happen from the outside, so that rather than making a large hole in the skull and having to move around parts of the brain to access the deeper parts, we could work from the outside with a small hole and proper coordinates. We could drive electrodes or whatever we were interested in doing deep in the brain through areas of the brain that we're not as worried about to those deep structures without having to cut through. So this was a very important innovation, and really the start of the field of stereotactic and functional neurosurgery, which is the field that you will be a part of if you choose to undergo DBS, or if you think it's appropriate for you. You'll be meeting with functional and stereotactic neurosurgeons. In the late 80s, Benabid was working with one of the most important people in movement disorders at Emory to fine-tune the kinds of surgeries that would then lead to deep brain stimulation. And then this team invented a chronic pacemaker that they could attach to an electrode, so that through the 1990s, there were studies investigating the utility of chronic electrical stimulation, which then in the late 90s was began to be marketed as deep brain stimulation, with the first devices approved for the treatment of essential tremor in 1997. So it's a long journey, right? But it really is a therapy that for the last 20 years or 25 years has been in heavy clinical practice and is very well integrated now into the professional recommendations of organizations like the Movement Disorder Society and the Michael J. Fox Foundation and the Parkinson Foundation, and a fundamental aspect of the way we treat and think about treatment of Parkinson's disease and other movement disorders. So moving on, how does deep brain stimulation work? Okay, so these are the three basic components of the system. The battery under the clavicle of the chest, it's the collarbone, is implanted under the skin. That's also called an implantable pulse generator because it generates electrical pulses. These pulses are carried by a wire that runs up under the surface of the skin of the neck and connects to electrodes here that are run under the scalp and then are implanted in the brain through two holes in the skull that are about the size of a penny or maybe a nickel. So these are the three components. The electrode itself is shown there at the bottom under the heading lead, and you can see those black areas are the electrode contacts, and those are parts of the electrode where the electricity can actually flow out. And you can see that different electrodes are designed different ways, but fundamental thing is that there are multiple electrode contacts on each electrode. That gives us the ability to stimulate in different places in the brain without moving the electrode. We can choose one contact or another, and that gives us some specificity depending on your anatomy and what your symptoms are, in where we want to send that electricity to exert the proper amount of symptom control without side effects. So any basic questions about the system before we move on? Okay. So taking a step back, in Parkinson's disease, you've probably heard of levodopa-induced dyskinesia, or those excess dancing, flowing type movements. Just raise a hand if you're familiar with that idea in Parkinson's disease. Okay, pretty much, I'd say probably 2/3, maybe almost everyone has heard of this. I think there's a confusion as to what these movements are. Some people think of them as a direct side effect of the levodopa and think about it as, well, if I take levodopa for a long period of time, the levodopa, or the Sinemet, causes these abnormal movements. And I want to take you away from that model and towards a different way of thinking about this, which is that the medications cause a change in symptom, and the kind of change that the medications cause over time is really dependent on what the brain is doing and how the brain manages the medication that you take. So early on in Parkinson's disease, which is shown here on the left side of this slide, every time you take one of these doses of levodopa, the brain takes up the medication and then releases it somewhat slowly. And that's because there's lots of dopamine producing cells around in the brain. It can take up all that medication, and then those dopamine cells can release it when it's appropriate. As Parkinson's disease changes over time, dopamine cells continue to be lost. And so the physiology, the way that the brain works, changes and continues to change. So when you take the same amount of medication, some of it goes into those dopamine producing cells, some of it sticks around in the fluid around the cells. And so the brain's response to the medication changes. Because of this change, I like to think of it as a change in buffering capacity, as that, if that makes sense to you. But the other way to think of it is like a change in the responsiveness of the suspension in your car. You know, if the springs are really, really loose, that car can take on a lot of ups and downs in the road and you might not feel it. If the springs become really tight, you're going to feel every single little bump. And that's what happens over time. The brain's springs become a little bit tight and the responses to that medication changes. So you have these big swings, ups and downs. And some of you might have experienced that. You have what are called motor fluctuations, or on-off periods, where the medications work for a period of time, but then they stop working before the next dose. And you might also start to experience these dyskinesias, these excess movements that are sort of dancing, flowing movements. Sometimes they don't bother people, and that's completely fine. Sometimes they do, or they cause pain, or changes in balance, or changes in function, or social embarrassment, whatever the reason. Sometimes those can be a bothersome symptom. And so people have swings of too much movement and too little movement throughout the day without being in this nice period of good treatment. So it's critical to understand that this is the brain changing and changes in the response of the brain to the medications over time. And this is when we like to think about deep brain stimulation being appropriate. Because what deep brain stimulation does, if you look at that blue region in the middle of this slide, deep brain stimulation broadens that window. So it loosens the suspension. It takes you from a state where the brain really needs a tight level amount of medication in order to respond properly to a broader, looser suspension where you can take the same amount of medications and have the same ups and downs, but your symptoms will remain well controlled throughout the day. Okay, so I kind of like that analogy of buffering capacity or suspension, but does that make a little bit of sense to people? Or are there questions about that? Okay. So that's the basics of how deep brain stimulation works. If you want to get into the neurophysiology and the experimental stuff and neuroimaging, I can do that in the question period. But the basic answer is we don't understand why applying electrical stimulation to this area or this area does this, improves the brain's response to medication. We don't truly understand what's happening, although there are some early ideas and early theories about what's happening that are really compelling and that are leading us in some interesting directions. We're far from understanding the complete mechanism. So let's move on then to factors to consider. We're going to start with who is a good candidate, what to expect of the surgery, and when is an appropriate time to do the surgery. So first of all, who? Am I a candidate for deep brain stimulation? So these are the most important questions to ask. One is that, am I sure about the diagnosis of Parkinson's disease? Most of the time we are. Some of the time we can be tricked up early in the course of someone's symptoms. There could be a disease that looks like Parkinson's that actually behaves differently over time. And you may have heard about these progressive supranuclear palsy, or PSP, or multiple system atrophy, MSA. These are things that sometimes come up in the course of some people's interactions with their doctors. But we can be fairly sure about the diagnosis after about 5 years. So if it's been 5 years since your diagnosis and your doctor and you are still settled on a diagnosis of Parkinson's disease, then that's a good amount of time to wait before surgery. The other important thing is that your symptoms, the symptoms that are impairing your quality of life, are responsive to your medication. So it might be that the meds don't last long enough or that they're causing side effects, but the important thing is that the medications do improve these symptoms, at least partially. Then you want to have number 4, these on-off symptoms, these motor fluctuations, and dyskinesias. Or sometimes if your dyskinesias are really, really bad throughout the day, you might not need a lot of fluctuation. Or sometimes if you have a lot of cramping pain or dystonia as a result of your dyskinesia, or maybe in the off state, then that's another thing to consider. But basically speaking, you want to be in a situation where you have both on-off periods and excess movements. And the reason for that, again, to give you another analogy, is that you're kind of between a rock and a hard place. To get rid of the off symptoms, you want to give more medication. But giving more medication is going to cause more of those excess movements, those dyskinesias. So that's the situation where the deep brain stimulation can broaden that window out and make it easier to treat you and easier to maintain good symptom control over the course of the day. Number 5, this is really important. You may have some symptoms that respond to medications and others that don't. For example, your tremor might get better with each dose of Sinemet or levodopa, but your walking and balance may not improve. So if you're somebody that experiences a lot of freezing, even when your medications are working well, and the freezing is what's really impairing your quality of life, then that's a situation where surgery may not be a good choice. And this is an example of a symptom responding to medication being the one that is impairing your quality of life. Because you all have a mix of symptoms, right? So there has to be a match between the symptoms that get better with the medications and therefore will respond to the surgery, and the symptoms that are impairing your quality of life. Okay? And just to restate that, if there's symptoms that don't respond to the meds, we wouldn't necessarily expect them to respond to surgery, and so surgery might not be a good option. Okay, and then there's a 6th category that you're unable to take medication due to severe side effects. If nausea or severe hallucinations or dizziness are preventing you from taking enough medication, then surgery can be an option, even outside of everything else that we talked about. Okay, and then finally, tremor sometimes, this isn't actually on the slide, and apologies. Tremor sometimes doesn't completely respond to the medications, but that's the one exception of symptoms that can respond better to surgery than meds. So if you have a lot of tremor, even when the medications are working their best, then surgery might actually improve the treatment of the tremor, even beyond that of the medications. Okay, so when is the best time to have DBS? You want to be in this moderate stage where you're having the fluctuations, the ups and downs, but you don't have a lot of failure to respond to medications at all. And maybe your gait and balance are relatively preserved so that you can do something like come to the movers and shakers meeting, exercise, walk around a lot, do your rehabilitation. So it's this moderate stage, often about 5 to 15 years into the course of Parkinson's disease symptoms, that you want to be thinking about whether surgery might be a good option for you. This is the other question that I'm commonly asked: how long does deep brain stimulation last? How long will it help me? Most symptoms that we target with DBS are going to continue to respond to the stimulation for the rest of your life, 10, 15 years or longer. That includes tremor, stiffness, on-off periods, and excess movements or dyskinesias. Some movements tend to get worse over time and not respond as well, but we're talking about like a decade in the future. Things like stiffness of the trunk and back, or general slowing of movements, if that's a real big issue for you, that your movements are so slow that it impairs your function. Over 5 to 10 years, that might become more bothersome and not respond as well. And then other things are never expected to respond. And we've hinted at these, but freezing of gait is if in the on medication period, posture and balance problems, trouble swallowing, and especially memory and mood issues, none of those are expected to respond to the stimulation. So we really focus on tremor, stiffness and slowness, and on-off periods and dyskinesia. It's a lot of information, but if I can convey one thing from this, how long does DBS last? It's a long time. For the vast majority of people, as long as you need it to last. And as long as we've been able to study it, it does improve quality of life and improve symptom control. But the important thing to note is that Parkinson's disease does continue to change. Deep brain stimulation doesn't change that progression. And so some symptoms are going to be more bothersome in the future. Some of those we can adjust the stimulation to treat them, and others may become more difficult to treat. So any questions about this idea? Okay. What to expect? Well, we talked a little bit about this, but this is best conveyed with a conversation with your neurologist in terms of what symptoms are likely to improve and which are not. Gait and balance symptoms, again, are the least likely to respond. How likely is it to be beneficial? In well-chosen patients, greater than 90% chance of significant benefit in your quality of life in well-chosen people. And how much improvement? Well, that really depends on what symptoms we're talking about. If we're talking about tremor, stiffness, and slowness, they may improve substantially, like more than 80% or nearly completely in the majority of people. Dyskinesia, we can almost usually completely suppress, although I would say always improve by greater than 50%. Things like dystonia, or that stiffness that occurs often when the medications have worn off, we can also significantly improve by more than 50% in almost all cases. And I think we've gone over these, but just to reiterate, some rules of thumb in terms of what to expect. The symptoms that respond to medications, especially those which fluctuate with medication dosing, ups and downs, are the most likely to respond consistently to surgery. Second, the best that DBS can do is your best on time with medications, and DBS can't beat that except in the case of tremor. All right, so that's kind of 2 and 3. So risks and side effects, we can go through this quickly. If you have more questions about this, we'll go through them at the end. But roughly, there's a 2 to 5% chance of acute side effects. So if we're thinking about the surgery, there's always a risk of bleeding and infection. And that risk is about 2 to 5% bleeding in the brain, but it's less than 1% of the time that bleeding causes symptoms. So sometimes there's a little bleeding around the electrode, but you don't actually see any symptoms from that. Over the long term, there's about a 3 to 5% risk of infection, and sometimes that infection would require the battery and the entire device to come out. So I would say that's about 1 in 100 or 1% in surgical centers that are experienced. So 1 in 100 cases, we would need to, over the course of the lifetime of the device, take it out and replace it. Obviously, that's something we would never want to do unless we have to. On the other side of things, there are side effects of the stimulation and the electricity delivery. So those side effects can include slurred speech, muscle pulling, worsening balance, cramping, changes in swallowing. These we can almost always eliminate by just adjusting the stimulation. That's the beauty of how flexible the stimulation is when we have multiple electrode contacts and multiple ways of delivering the stimulation pulses. But if we can't get around a side effect and there's persistent side effect despite everything we do, in the worst case scenario, we just turn the electricity off and the side effect would go away. But essentially, we never have to do that. So the DBS journey is, briefly speaking, about 6 months. So your evaluation with neurology and neurosurgery is conducted first. Then you have a 4 to 6 hour neuropsychological evaluation to assess for any memory changes or mood changes. And the reason is that we want to understand exactly what those symptoms are before proceeding to surgery, because some ways of doing the surgery can put a person at risk of worsening memory issues. So if those are present, then we want to avoid those methods. The stage 1 of the surgery is the electrode placement. That usually takes place under general anesthesia and involves an overnight stay in the hospital. Stage 2 is implantation of the battery. That happens 2 weeks later, and that's a day surgery. And then you wait another 2 to 4 weeks before turning the device on. And the process of initial programming takes place over about 2 hours. So if you've been adding things up, we're now about 6 weeks after the initial surgery. And then you probably want to tack on an additional 6 to 12 weeks of optimization for the programming. So by the time you've recovered from surgery and the programming has been completely optimized, we're around 3 to 5 months after the surgical procedure. So it's a process, but you will likely feel substantially better even after the initial programming. So it's a process, but there is some payoff early on. Okay, so where, how, and what? I'm going to just breeze through some of these options because I want to give lots of time for question. There's 3 places in the brain that we can do the surgery for Parkinson's disease, but really most 90% of the time we're doing it in either of the GPI, that's the globus pallidus internus, and the subthalamic nucleus, or STN. The main advantage of the STN is that we can decrease medications after the surgery. The main advantage of the globus pallidus is that we have a really strong beneficial effect on excess movements like dyskinesia and cramping pain dystonia. So depending on what your symptoms are, you can talk with your neurologist, and usually the neurologist and the neurosurgeon decide on the target based on your symptoms and what your priorities are. At University of Southern California, I will plug our wonderful program and our neurosurgeon, Brian Lee, who's the only neurosurgeon in Southern California who has been trained on asleep deep brain stimulation. So this is a technique where the surgery is conducted entirely within the bore of an MRI scanner. And so you don't have to wake up during the surgery to do any physical examination testing or any brain cell electrical recording. That's the normal process during this surgery. In awake deep brain stimulation surgery, about an hour into the surgery, we wake you up. The neurologist, like me, examines you and looks at the brain cell recordings to make sure the electrode is in the right place. The alternative, if you are very bothered by the idea of waking up, or if your movements are so severe that waking up would cause a lot of pain, is a sleep DBS. And it's nice to go to a neurosurgical center that offers both techniques. So Brian trained up at UCSF with Dr. Phil Starr, and he's one of the leaders in development of this technique. So Dr. Brian Lee now works with us at the University of Southern California and is one of our 3 neurosurgeons, along with Darren Lee and Mark Leiker. So it's nice to have option doing the procedure asleep and awake. And here are the three devices: the Abbott device, the Boston Scientific device, the Medtronic device. They all have their advantages and disadvantages. I've listed them there in case you want to take a picture of the slide. Basically, the Abbott device allows you to program remotely, and I'm going to get into that. The Boston Scientific device allows for image-guided programming, and I'm going to get into that. And the Medtronic device allows recording from the brain, and I'm going to get into that as well, very briefly. Probably the more important decision that you have to make is whether you choose a device that is, I like to call it single charge or rechargeable. So a single charge device goes in, you don't have to think about it until the battery runs out. Usually that's about 3 years. So it has a 3-year lifespan. A rechargeable battery has a 15-year lifespan, possibly more, but you have to spend about an hour a week. It's getting less and less, sometimes an hour every 2 weeks, sometimes an hour every month, but you should expect at least an hour a week of charging. So you're watching television, you sit with a little inductive charger, it's a little pad on a sash, and it charges the device through the skin, just like a charging pad for your iPhone. All right, so those are the two options for the kind of battery that you could use. And so putting this all together, there's really no best option. All three of these devices have good advantages and disadvantages, and rechargeable versus non-rechargeable or single charge. They're all great. They all deliver the electricity properly. You'll get benefit from all of them. And which one you choose is a nuanced decision, and that's best made with your neurosurgeon and your movement disorder specialist. Okay, finally, new and future innovations. First of all, what kind of alternatives to DBS are coming down the pipeline? So there is something called continuous delivery of Cinemet, and that's going to be under the skin. So there's two products, the product from AbbVie and the product from Neuroderm. And these products are both in the final stages of trial and FDA approval. And they can improve on time throughout the day and reduce dyskinesia. So this is a really nice alternative to DBS, probably for a period of time. It's probably not going to be as beneficial over a long period of time. But if you're not a candidate for deep brain stimulation, or you're just really averse to the idea of a brain surgery, this is an option that's coming down the pipeline for you. The downside is that you have to place the needle under the skin for continuous delivery of this medication, and that causes inflammation, or what's called nodules under the skin. So that requires you to change the location of the needle, but the needle would stay in for a few days here, a few days here, a few days here, and you'd kind of have to rotate that needle around. Doesn't happen in everybody, but that's the major side effect of this continuous levodopa delivery. And probably a lot of you have heard of MR-guided or MRI-guided focused ultrasound therapy. This is marketed as a non-invasive alternative to DBS. And I am biased. I will fully admit my bias as a DBS specialist. But I would encourage you not to think about this as an alternative, but as a backup for people that are not candidates for stimulation. To the best of our knowledge, this procedure causes more long-term side effects, and also is not as good and is not currently approved for treatment of both sides of the body to reduce fluctuations and dyskinesias. You can use it to treat tremor, but if you're using it to treat tremor, all your other symptoms are still going to stick around and require medication treatment. What's more, this therapy, although again very powerful and it has its use, it is it is basically burning a hole in the brain. So though it's billed as a non-invasive alternative to surgery, what you're doing is killing an area of the brain. In deep brain stimulation, you're stimulating that same area and you're changing its function, but you're not causing nearly as much cell death. Basically, the only cell death you cause is in a very small area around the electrode, only during the initial surgery and implantation of the electrode. But in MR-guided focused ultrasound, it is burning a hole in the brain. So if you're interested in this procedure for treatment of tremor, then it's definitely a good option for tremor treatment. If you're thinking about it for treatment of other symptoms, I would certainly talk to your movement disorders specialist about it, and definitely consider deep brain stimulation as the more tested and well-established therapy. Okay, so now I'm already 5 minutes over my intended time. So these are the three future innovations and, well, really present innovations, excuse me. The first is with the Boston Scientific device, this image-guided programming. So you see, this is what we actually see on our programming tablet in the office. And these bubbles in red, green, blue, and orange that you see, these are your neuroanatomical brain structures recreated in 3 dimensions on our programming tablet. And this isn't a standard atlas. This isn't like a mock-up of what they should look like. This is actually a reconstruction of your brain that we obtain by using your MRI. So this gives us a roadmap of where to send the electricity to avoid symptoms, to avoid side effects, and to improve symptoms. It's not always necessary, but it can be an excellent tool in the clinic. The second thing coming down the pipeline is this idea of adaptive deep brain stimulation. So here there's a couple of examples of thermostats, one that you've seen over the last 40 years and one Nest thermostat that's a little newer. But the idea here is that the thermostat takes in a signal, that's the temperature of the room, and outputs a signal, that's an electrical signal to your furnace. And the furnace turns on and it changes the temperature, which then feeds back to the thermostat. But the thermostat facilitates this closed loop. And that's what we're trying to do with deep brain stimulation, is use some kind of input to change the way that we stimulate the brain. And then that stimulation perhaps could change the input itself. So some of those inputs could be wrist monitors. For example, the tremor on your wrist could signal the deep brain stimulation to start, right? Another signal might be a intrinsic brain signal, or the activity of brain cells around the electrode. And that's what the Medtronic device is offering. This is a screen from the Medtronic device that we can use in clinic now. And these waves that you see on the right-hand side, this little peak, is brain cell activity that the device is measuring. And we can use that activity as a way to understand what symptoms might mean. And in the future, we may be able to use this brain activity to trigger or change the deep brain stimulation in this closed loop fashion. So the ADAPT PD trial is ongoing right now. That's running out of Stanford and other centers. It's really exciting. And we had some initial results at the Movement Disorder Society conference last year that showed possible benefit, but certainly equivalence in symptom control. So we're just learning to use these techniques. The last innovation is remote programming. This is the Abbott device. This allows us to adjust the neurostimulator from afar. You can be in your home, connect to a secure portal. I can be in my clinic with my iPad, my programming device, and you have your little iPhone. We see each other over a video link, and I can adjust the stimulator from my office over the internet into your battery. And this happens over a secure portal. It's safe. It's compliant with all privacy laws, and it's safe from hacking, so to speak. So this isn't something that somebody could break into and adjust your stimulator if they had some reason to want to change your tremor control or slowness control. So this is it's safe. It's been in use for a few years now, and people tend to really like being able to adjust the stimulator from home. All right, this is my shameless plug for our wonderful team. You can see our 3 neurosurgeons there at the bottom: Darren Lee, Brian Lee, Mark Leiker, and my colleagues in neurology, Jennifer Huey and Nazrin Esnashari, and Andrew Petkus in neuropsychology. And that's just a small part of our team at USC, but this is the core group that runs our deep brain stimulation program. So thank you. I'm going to stop my screen share, and then we can talk questions. So thanks so much for your attention. Yeah, so tremor is, I know that I really drove home the point that the symptoms that respond to medications are the ones that are going to respond to surgery, right? And that surgery can't do any better than medications can. However, and I'm glad you asked this question, tremor is the exception. Tremor can respond better to surgery. So if we're trying as hard as we can to treat tremor with medications and we just can't get where we need to be, deep brain stimulation is a really good option and can reduce or eliminate the tremor that is not responding to medications.
Dr. Mason, I know we had a question in the chat.
Oh yeah, okay, let me pull it up. DBS can be used only for Parkinson's, or can it be used for other movement disorders? It can be used for essential tremor or other forms of tremor. It can also be used for dystonia. Dystonia is a symptom of Parkinson's disease, but it can actually exist on its own as a condition called, well, as many, many conditions. But it can exist without Parkinson's disease. And when we have dystonia alone, we can use deep brain stimulation. It can also be used to treat tics. And finally, for obsessive compulsive disorder in the psychiatric realm. It's being investigated for treatment of some pain conditions. It's being investigated for treatment of some headache disorders. And finally, for treatment refractory depression. So all of that to say, yes, there's lots of other movement disorders it can treat. But in terms of the ones that look like Parkinson's disease, Lewy body dementia, progressive supranuclear palsy, multiple system atrophy, and finally corticobasal degeneration, I'm just listing those in case those are familiar to anybody. Those we do not typically use deep brain stimulation, almost never. And the reason is that they tend to progress more quickly and they tend to respond less favorably to DBS. But it's not an absolute 100% no. Sometimes, in some cases, DBS can still provide palliative treatment that is meaningful. It can improve some symptoms to affect an improvement in pain or quality of life in some way. So we don't withhold it in a patient who we think it may be able to help just because of the diagnosis, but that is quite rare. I'd say in 95% of cases that carry those other diagnoses, we would not use deep brain stimulation.
You mentioned that there are 3 different locations where they can place the electrode. And just let me know if you can't hear me very well.
I can hear you.
Okay, perfect. And so would there ever be a case where you're placing the electrode in one location on one side of the brain and one location in the other side of the brain to treat? Because my understanding is that you're putting it in that part of the brain to target certain symptoms, right? Would there,
exactly,
like if I have tremor in my left hand that's really significant, but I also have dyskinesias, would you put the electrode in different places, or is that just how you stimulate, how you choose where the electrical stimulation comes out of the electrode? Or
So you usually, the simple answer is that you would usually put the electrode in the same place on both sides. And the reason for that is that although some symptoms respond better to stimulation in different areas, we can usually hit all symptoms to some degree. And moreover, when you stimulate in one place on one side and the other place on the other side, sometimes it's hard to balance the symptom control for both sides of the body. With medications, it can become really difficult. So we almost always choose the same target on both sides for that reason. But that said, we still can control most symptoms, even with one site. The key is choosing the right site for the right person. And there was one more thing that you said. Well, I can't recall, but Brenda just put another message into the chat. She said, my sister was initially diagnosed with Parkinson's. Now, after being tested in a memory clinic, they say that she has Lewy body dementia. Is this a common misdiagnosis? It can be, and it is a spectrum. So sometimes people fall on one side of the spectrum quite early, other times not. They're in that overlap zone. So Lewy body dementia, deep brain stimulation has been used in Lewy body dementia, depending on the symptoms that are bothersome. But in that disorder, the mood, hallucination, and cognitive or memory symptoms tend to be the ones that are causing the most impairment in quality of life. And DBS is not going to improve those symptoms. Now, if you had somebody with really, really bad memory and really, really bad hallucinations who was having bothersome dystonia or dyskinesia or tremor, DBS could be used to treat those symptoms if they weren't responding to the medication, and that could potentially still improve quality of life in that situation. So that's why it's a nuanced conversation. It's just a most of the time guideline. We would not use it to treat Lewy body dementia. Well, if I could say with 100% certainty, I'd be a rich man, right? But the likelihood is that some symptoms are going to crop up on the other side over time. We don't know when that will be. That's why Dr. Starr put that extender, right? You want to be ready for that moment if it happens. There's no certainty. And sometimes people really stay one side predominant for decades and don't have symptoms on the other side. So that's why sometimes some surgeons choose to just do the surgery on one side, as Dr. Starr did for you. Yeah, well, I wouldn't be doing my job if I didn't say none of these surgeons are as good as Brian Lee, Darren Lee, and Mark Leiker, right? Of course, at USC. Right. Well, yeah, that's exactly right. It's a small community, right? It's a close-knit family. But what you really want to do is find a surgeon whose approach makes sense to you. Somebody who, when they speak to you, doesn't, of course, you want to get along with them, but somebody who speaks your language, that's not saying a lot of things that don't make sense to you, whose approach seems intuitive. And that usually means that they appreciate the things about you that are important, the parts of your life that you want to preserve, the parts of your function you might want to improve, your values and your priorities, right? That usually comes across when you're meeting with a surgeon and a neurologist as sort of intuitive advice, because they're listening to you and they're giving you advice that fits with you. And so if somebody's saying things to you that, maybe they're factually correct, but they just don't jive, that might be an indication that you should see somebody, seek a second opinion. Well, there's not that many surgical centers in California. So if we're talking about people who are in California, you're looking at UCSF, Stanford, UCLA, Cedars, University of Southern California, and Loma Linda. And then there are, of course, there's like Huntington Hospital down here. There's smaller surgical centers in different places. But if you're looking for the academic centers, those are the big ones. So there are a number of ways to go about this. I think it makes the most sense to talk to your movement disorders neurologist and see who your doctor has had good experiences with in the past. They've referred people to those programs and they've done well. There's been good communication with those programs and your doctor's office, right? Sometimes your doctor will want to do the programming themselves, and if that's the case, there needs to be a good collaborative relationship between the location that does your surgery and your doctor's location, right? So that you can kind of talk back and forth about what the programming is. So starting with your movement disorders neurologist is a good choice, good place to start. The alternative would be to, go to one of the centers that I've listed and search for their DBS program and book an appointment yourself with a surgeon that you think you would fit with based on their reputation or perhaps their publications. And a third route might be to go through the device companies and ask and contact one of the device companies. They're always very, very adept at speaking to patients who are interested in DBS and connecting you with your local device representative. And then that device representative would then put you in touch with a local, an implanting center that they are well connected with. If you went that route, I would probably contact all three of the device companies and see who they're sending you to, and then choose one based there. But that I would say would be the third way to go about it on my list. First would be to start with your doctor and see who they like and they've referred to in the past and why. Second would be to choose a center yourself and meet with a number of centers and then choose who you like the best. And the third would be to go through all three device companies and get their recommendations. Oh, and then I guess, the other part of your question is, how do I choose who I like? And I've touched on that a little bit, right? Is that that interpersonal dynamic is important. The other is a flexibility of approach. If you have somebody who says, nope, this is the way I do it every time. I do it this way every time. I found that I have good outcomes when I do it this way every time. I think that is that lack of flexibility is usually less advantageous to a patient than somebody who is willing to look at your situation and say, well, here we could do it this way because of X, Y, and Z reason. So that's important. And that comes down to what device does the surgeon want to implant, and do they use all three or do they only use one? That comes down to the other option I told you about. What kind of battery, rechargeable or single charge? Do they only ever use one? It comes down to the location of stimulation, the STN or the GPI. Do they only ever implant one, or do they do both? And finally, the method of surgery, asleep versus awake. Are they only capable of doing awake surgery, or can they offer you both asleep and awake? Ideal would be to go to a surgeon who is well versed in all of those combinations. And I can say that that's a priority we have. That is something we've made a high priority. Again, not to give you the hard sell, but this is our philosophy, and my philosophy is something we've made a large priority at our center because I think it serves patients the best. Other people have a different philosophy, and that's fair. They want to do things the same way every time because that allows them to, get the best outcome. I think that you can get the best outcomes when you tailor treatment to an individual, and that would be my recommendation. And I would leave you with that, I think. So usually we can certainly do that. Yep. Yeah, you can put both electrodes in, and you can stimulate one only very, very gently, or not even turn it on at all. It's usually not the case that we would do that. Usually if we put it in, we're going to see if it can give you at least partial benefit. Because if there's no side effects, there's no downside. The only downside is really using a little bit more juice for the battery. Does that answer your question? Oh, yeah. So certainly that has been studied to some degree. It carries additional risk to put 4 electrodes in than 2. And so because we know that just putting 2 in works so well, it's a hard study ethically to justify, because it comes with additional risk without an expectation of additional benefit. And so it hasn't been studied in large trials. That said, every center has a few patients who have 4 electrodes in place because things have changed over time, and the situation has needed to be salvaged with an additional surgery. And so that certainly happens. That's a conservative statement, and it's probably the case that you would not need the rechargeable to be replaced. They might last 25 years. But it's not something that we can say confidently because we haven't been able to study that very well. So with one of the devices, with the Abbott device, we can do everything remotely, correct? If it is a single charge battery, non-rechargeable, so to speak, then we can directly measure the voltage of that battery remotely and determine when it needs to come out, whether that's in 3 years or 2 years approximately, or approximately 3 months. We can get a sense of that based on the voltage number, which we monitor every 3 months because we typically see people every 3 to 4 months. The rechargeable battery is a little trickier. That's something that we only really ever get a percent charge. That's not true. We do get a voltage reading, but it's not as meaningful because that voltage fluctuates up and down every day and increases when you recharge it. So if you're asking how we get a sense of the long-term lifespan of a rechargeable battery, that's much more difficult. That comes down to how well is it charging, how efficiently is it charging, is the charging working, or do you have to charge more and more often? And that is much more nuanced. It doesn't come down to a single number. But in the majority of cases, that rechargeable battery just lasts a lifetime, so to speak. Yes, and it is dose dependent. So that's not a reason not to increase the stimulation if you need to. But if your physician increased the stimulation by 20 to 30%, then the battery might only last 5 or 6 years instead of 7. Right? So there is a relationship there. The most important thing is symptom control. No, it's pretty simple. It's an incision in the chest. Battery comes out. New battery goes in. That's a day procedure. So not under general anesthesia. The major risk, that's an important point, is infection. So the more times the battery comes in and out, the more likely you are to have an infection in that space around the battery. And that infection can spread up the wire, and in rare cases, or in some cases, that requires the whole system to come out and be replaced. So that's another advantage of a rechargeable battery, is that with fewer replacements, you have a lower likelihood of infection. The infection risk is still low. It's still only 3 to 5% over the lifetime of the device, even with, 3 to 4 battery replacements on average. But that is certainly something to consider. Otherwise, the surgery is quite safe, right? Like the bleeding, the blood loss from a small incision like that is minimal. There's just a little bit of pain from the battery replacement. There's no general anesthesia in most cases. And so the surgery itself is safe. It's just the risk of infection every time you make an incision in that pocket. Well, I think if first of all, it is always possible to just offload this decision to your surgeon and your movement disorders neurologist, and that's completely fine. And I think your expectation should be that people make the right choice for you. And if it's something you want to take on and do your research, all the better. But it's not necessary to do so. I just don't want people to feel like they're responsible for that decision. The real answer to your question, though, is that while it is possible to swap the battery out for another manufacturer, it's not possible to swap the electrodes. So once the electrodes are in place, they're in place, unless they need to come out because of an infection. And if you change the battery from, say, a Medtronic to a Boston Scientific or Abbott battery, if you swap it out, you would have the capabilities of that other company. But you would also have a system that's mixed. You would have one company here and another company with the electrode, and that can make it very difficult to get an MRI scan. So although all of these devices are compatible with MRI, when you start to mix them, it becomes much less likely that you could get an MRI scan in the future. And for most people, it will be necessary to get an MRI in the future. So we really want to facilitate that and avoid mixed systems if we can. No, I haven't seen that. And that's because the electrodes are placed in areas of the brain that are generally quite far from aneurysms. Quite far is relative. We're talking about centimeters and inches. But for a neurosurgeon, that's a long way. So no, I've not seen that, but that's an excellent question to ask your neurosurgeon, whether he or she thinks that the location of the aneurysm will need to change the approach to the surgery. If you would need an MRI scan for another health issue. So for example, if you tore your rotator cuff, or you had symptoms that made us concerned for a stroke, those would be situations where we would need to get an MRI scan, and we want it to be very easy for you to do so. Yes, you can get an MRI with these batteries, with these systems. They're MRI compatible. Yep, exactly. So you can turn it off on your own as long as there's no issues with the electrical circuits. It's as simple as turning off a device and then turning it back on after the MRI scan. Yeah, right. And some of the systems do have that. Others would require you to just turn it off. I probably have another. I have a 12:10 meeting, but I probably have enough time for one more question.
We appreciate your time and all the information. It's been very informative. Yes, thank you.
No, yeah, of course. And just one last call if anybody has anything, or if not, Jessica, you have my email address, and please feel free to share it with the group. If anybody would like to speak, we can always set up a telemedicine visit if there's something formal, or if not, if it's just informal and you have a question, feel free to shoot me an email. Okay, I can't offer medical advice over email, but I mean, if there's things to do with the system, your pathway through this process, I'm very happy to help.
Thank you, Doctor. Thank you.
Okay. Bye, everyone, and enjoy your Saturday, and good luck. You guys aren't going to get as much rain up there, but still, good luck.
Yes, thank you. Same to you.
Bye.
Bye.